I think we'll begin. Hello, everybody. My name is John Wilkes. As I said, I am the Chief Executive of the Institute of Health and Social Care Management. I'm joined today by my fantastic colleague, Emma Caton, who is our Memberships Manager at the Institute. I just want to welcome everybody and thank Guy's and St Thomas's for agreeing to undertake this showcase session, really focusing on what we can learn from systems failures. And we've got particular emphasis today on maternity services for obvious reasons, with the benefit of recent issues that have occurred, let's put it that way, and the various reviews that have taken place. That's enough from me. I'm going to hand straight over now to Daghni Rajasingam, the fantastic Deputy Medical Director at Guy's and St Thomas's. Daghni, over to you. Thank you.
Thank you very much, John. I think I know most of you, but not all of you on the call. We will have people joining, as John said. My name's Daghni Rajasingam. I'm an obstetrician in the organisation and Deputy CMO, but I have a regional role as the Regional Obstetric Lead in South East of England. And we've brought this session to you not just as a focus on maternity, but because systems are systems and there's much to learn from systems, especially when they're failing. So I am absolutely delighted to welcome our two speakers, Fiona Wise and Tony Kelly. I will introduce Fiona, who's going to talk to us for a short while. We'll have some specific questions for her if you would like, and then we'll move on to Tony's presentation, and then we'll have them both for some slightly longer questions and answers, if that's all right. The session is being recorded. There was a lot of interest in it, so we will record it and make sure you have access to that. So without any further ado, it's my delight to introduce Fiona Wise. Fiona has been operating within the NHS for a long time, over 23 years as CEO in various organisations, and her most recent role was as Strategic Programme Director for East Kent Hospital, which is how I came across Fiona. And she does indeed have some wise reflections of her time in the NHS, of supporting organisations and systems that have been failing. So without any further ado, Fiona, over to you.
Good afternoon, everybody, and thank you very much for inviting me to share some of my experiences. And I will particularly focus on East Kent, but I thought it might be helpful to just say a little bit more about myself and the context of this, and then to say a little bit more about what I actually did in East Kent. And then I've got 4 very short slides that I just want to put it together with the themes and what I think are some of the successes that are beginning to emerge. So I've worked in the NHS probably longer than I care to remember, and I was the Chief Exec at Northwick Park Hospital, which was part of North West London Trust back in from 2007 to 12, and Northwick Park was put into special measures for maternity failures back in 2007, just shortly as I arrived. That was my first big experience of a challenged organisation facing a number of issues regarding maternal deaths. During my portfolio career after my retirement or semi-retirement, I was invited to go to Morecambe Bay. So I worked in Morecambe Bay for a while, supporting the independent investigation into maternity services there as an employee of Monitor at the time. So you begin to get a bit of a theme about my experience of working in maternity and neonatal services. And when I was then approached by East Kent to support them following the announcement of the independent investigation, I was able to bring some of the experience I'd had both at Morecambe Bay and Northwick Park. Now, my insights, particularly around East Kent, not just come from the report, but particularly my role in supporting the trust. So I was supporting them in developing their maternity improvement plan, but my key role was the interface with the independent investigation. So through that process, I had an opportunity to talk to everybody that was interviewed by the independent investigation, and that subsequently was very, very involved with working with families. But it did provide for me, prior to publication, a very clear pattern of missed opportunities, and actually a very scared group of staff who were very aware of what had been going on and some of the difficulties. But it was, I think for me, quite a harrowing experience, I think is the best way to describe it. And I don't think we can ever underestimate the impact of tragedies on families and staff. So I suppose where I've come to on this is I just took a step back and thought, well, actually, we're now in 2023, and I first came across some of these issues back in 2007. And let's just have a little think about it. So what I've tried to do is just pull together the themes from the investigations that I have been involved with directly, but also looking at what happened with SAF and the national CQC maternity review. And I'm also just going to touch up very briefly on a non-maternity one, just to, I think, reinforce the point that this is about system learning. And whilst there is a really big focus around maternity, it's not just in maternity services this happens. So, as I said, I've got 4 relatively short slides. I'm not going to talk to them in detail, and they are not too complicated, I think. John, it'd be really helpful if you could put the first one up. Thank you. So there's been a series of maternity reviews commissioned by Trust and the CQC and independent. Northwick Park, which I've touched on in 2007. Key themes from that were clinical competence, culture, poor working relationships, and poor governance. So the Trust did not know when it was put into special measures about the increased number of maternal deaths. I mean, that was the absolute bottom line at the point time there. I then went to Morecambe Bay, as I said, in 2015, so 8 years later. And surprise, surprise, or not surprise, surprise, the key themes from Morecambe Bay were about clinical competence, culture, risk identification, which is part of governance, and failure to investigate. So we then get to Shrewsbury and Telford. Issues about escalation of concerns, poor governance, downgrading of incidents, poor working relationships, and clinical competence. So I think it was shortly after that that the CQC did a national review of maternity services, or started their national review, but they published a report about their findings. So they use slightly different language, but ultimately it is concerned with lack of leadership, choices for women, staff engagement, and data and risk. And then we get to East Kent. So monitoring of performance, organisation, behaviour and culture, ethical behaviour, and clinical competence. I mean, there are nuances between all of the reviews and different groups of staff involved and different issues, but underlying it is the same particular issues, which I'll touch on in the second slide. But I just wanted to flag up Liverpool Community Review, partly because Bill Kirkup was involved in that review, but it's about a community trust. It's not about maternity services. And 2 of the key findings of that were ineffective risk management and lack of ownership and management of risk. So I would just say that really to reinforce the point that these are about systems failure. And the thing I always say, and have always said as a chief exec, staff do not come to work to cause harm to either the colleagues they work with or their patients. It is often systems that do not support them in the delivery of the care that's required. John, would you move to the second slide for me, please? So the maternity reviews identified common themes, and you will be aware that Dr. Kirkup's review of East Kent took a slightly different approach, in that he was saying, what are the key challenges? What are the things that people need to do? And I think that's because he was particularly, well, I know, and he said fairly publicly, I did a review in Morecambe Bay. Where's the evidence to see the improvement? And therefore, I want to focus particularly on the themes. And then, of course, the NHSE maternity strategy was published and has set out a number of actions for trust and systems. And I've just tried here to kind of simplify it and perhaps align it with the findings of the reviews. So there's something about working relationships and culture, clinical decision-making and effectiveness, risk identification, and ensuring women's voices are heard. And then I've really just lifted here a very brief summary of what I think the maternity strategy is actually saying. So it's about listening to women and families. It's about supporting the workforce and developing a culture of safety, as well as improving standards and structures. It's a very brief summary, but it's a high-level oversight that tries to align with the findings of various reviews. So I wanted really to talk about what I see as the potential solutions, and I'm sure Tony will add to this, and I hope that we don't say anything that's contradictory in a sense. But if we perhaps turn to potential solutions, which is the third slide, John. And what I'm going to do in the fourth slide is talk about some of the specific things that East Kent have implemented in response to reading signals. So I've tried to group them into processes for improvement, the need for a culture of continuous improvement, the use of data and digital solutions, and future service developments. So robust SI processes, including all clinicians. I have to say, but in both Northwick Park, Morecambe Bay, and East Kent, and it wasn't, well, and South too, actually. There's no evidence that all clinicians are equally involved in the SI processes, and there's often a particular profession that will take a lead. The importance of care pathways, including triage systems, and it's quite open that most of the recent CQC reviews have picked up particularly on the ineffectiveness of a number of triage systems. Systems of assurance, not reassurance, including independent oversight and supporting evidence. I think a big learning lesson for me, and we all learn all the time, is the difference between assurance and reassurance. And it's quite easy to go to a board and say, don't worry about it, it's all right. But where is the evidence that it is all right? And so one of the big things that happened in East Kent was collecting the evidence to align it with the improvements that were being made. So a lot of post-audit of saying, has this actually happened? Where is the evidence that it's happened? Not, oh, well, we know it's happened and it's okay. So there are three of the key things around process improvement. And then the culture of continuous improvement. So that's about culture of safety and organisational development. And I suppose for me, I may touch upon it a little bit more. Often what happens in organisation is organisation development is done to staff. And actually staff need to lead the change and the organisation development. And people often talk about the model of quality champions, but there's also the NHSE programme of organisational development that has got clear evidence attached to it that if you involve staff in this, then they feel more engaged, and then you get your alignment with the results of staff engagement, the National Staff Survey. Real-time family and staff feedback and involving them in service design. And I'll say a little bit more about that in a minute in terms of East Kent. Now, I'm a big fan of SP analysis. So it's making data count is the other terminology that's used for that. So I know from discussions with Dr. Kirkup and others, and indeed my own experience, that the things that are particularly important to look at in terms of maternity are unexpected admissions to intensive care. And I've often wondered, is that neonatal intensive care or is that adult intensive care? And I think it's both potentially, depending on whether the incidents are occurring with babies or mothers. And then also being very clear about variation around interpartum, stillbirth and death. And there's a thing that I know Dr. Kirkup talks about, and I need to make sure I pronounce this correctly, poison distribution. So that is how variation is distributed. So there is really, through using SP analysis, the opportunity to delve deeply into variation. And as I said, for me, they are key things to look at. Because there is, I know from conversations I've had with other trusts and in East Kent, there's a real danger at the moment that we produce reports to the boards that are like 40 pages long. And if you're looking for assurance, not reassurance, what are the key things to look at? And I'm not, in terms of, so that's data, but also digital solutions. And then future service developments, key to getting robust care pathways in place, particularly in Northwick Park, Morecambe Bay and East Kent, it is reviewing maternity and neonatal strategies. So, some of it's not rocket science, to be honest with you, but it's about, where do women give birth? What are the indicators that they should be in a much bigger unit rather than a small unit? And then obviously workforce development and planning. So for me, that's how I would group the potential solutions, and they align to support the national maternity strategy. So what I was just going to talk about finally is a little bit about some of the East Kent Pacific improvements. And I believe East Kent have come out of the special measures, is that correct as well? So I think that is evidence that some of these things are particularly working. So John, perhaps my fourth slide, if we could. So, so the trust, these are not in any particular order, but I'll just talk a little bit about them. So the trust implemented something called Your Voice is Heard. So every mother, 6 weeks post delivery, had a one-to-one conversation, or the opportunity for a one-to-one conversation with a midwife to talk about their experience. And the take up of that has been between 70 to 90%. So a really good level of take up. And what was interesting about that is what you think that they'll talk about isn't what they talk about. And the things that have a lasting impression on their experience. And actually the trust in the beginning of the programme learned that actually it was the antenatal care that was the most concerning for women rather than the actual delivery. Then the second thing was the importance of a cross-site maternity strategy. Now, I probably should have referred to it as a neonatal one too, but East Kent's a very large trust. Got 3 sites it delivers maternity services on, 2 main hospitals, but a very clear decision that for any women who were about to deliver at 32 weeks or less would no longer deliver at Margate, because there was only a SCBU there and not a NICU. And for women that was quite a hard decision for them and needed a lot of explaining, but it was an important outcome of the strategy. I just cite that as one. The trust was an early implementer for the National Call for Concern initiative managed by the Clinical Critical Care Outreach Team. It's Martha's Rule in a sense, or the predecessor of Martha's Rule, which is about families having the opportunity to talk to someone independent of their care. Robust response to staff concerns. The trust invested in 2 freedom to speak up guardians for maternity only. A big investment, but it began to pay dividends in terms of staff feeling able to speak up about their concerns. And then if you to the next three bubbles, I'm really going to talk about the middle one really, which is the trust decision to set up a reading the signals oversight group that involved any of the families that wanted to be involved. And that was an opportunity for the families to, I think, in many ways, continue their grieving process, but also to begin to think about what really needs to change to make this different. And one of the main things that came out of that was the co-production of care pathways. So the Trust has recently won some awards for the work that they've done on their bereavement processes, which were co-designed with families. And actually, the families who had lost babies were really good for them to stand up and be prepared to help. The last one's a bit of might seem to you quite obvious, but the need for a regulatory tracker. So where are these reports or reviews that go on in maternity services or any service? Where do they land? How do you know that you're implementing them, that you get assurance that the changes have been made? And actually, one of the biggest challenges for me in East Kent was when the investigation was asking me for this report or that report, I couldn't find them because there was no composite place where there was a list of what had come into the Trust and what the Trust had done about them. And I have spoken to other chief execs in my journey over this who say, well, actually, I'm the regulatory tracker, and I personally think you can't be. You do need to root it somewhere properly on a Datex system or some sort of system. So I'm conscious my time is probably up, so I'm not really going to spend a lot of time on the bottom line. And Daghni, you'll be very familiar with the notion of caring with compassion videos. The Trust made its own. It wasn't about maternity services, it's about end-of-life care, but really important to think about the impact of the patient care pathway on all staff. I've talked about freedom to speak up and the independent SI process, duty of candour, and meeting with families, and then actually having a strategy group that had oversight of the improvements that were required. So I think these composite things really are beginning to show improvements in the Trust. And I think the importance of both the families who have given birth or are about to, but also staff in terms of the quality of care that's provided. So I hope that was, well, these are my reflections.
Thank you so much, Fiona. I think it is incredibly helpful and useful to have reflections that go back, and it will be 16 years now since 2007. I've put a few things in the chat about Northwick Park, the predecessor of the CQC that many of you will remember, the Healthcare Commission, the state of maternity services in London. And then we do have a question from John about these continuing scandals emerging, the place of independent reviews, focusing on monitoring key data. It is an issue. And I wonder, Fiona, John's question was really around, should we not be monitoring key data and then use the best providers to support those with challenges, some support? So I'm going to just get your thoughts on that, and then maybe John, you might want to come back on that answer.
Well, I mean, I touched on it in a little bit, didn't I? Which is, I'm a really big fan of making data count, and I had the privilege of working with Sam Riley, who's the proponent of that, because she was my director of strategy when I was chief executive of Ealing Hospital. So I've been introduced to this really early on, and I divert here, but it is important. So we improved our A&E performance by using SP data analysis, because it was that deep dive of actually what is the variation and what is the real variation that is impacting on it. So I think that if trusts have robust assurance processes, not reassurance, then actually using data properly, they should be aware of their shortcomings. So I believe that very, very strongly. And I do think there's a really important role of the women and families' voices, whether it's maternity or elsewhere, in terms of what it feels like really, and what it feels like for staff too. So, you know, if you were using your assurance processes properly, both in terms of data and feedback from families and staff, then one would hope that you might avoid the independent investigation scenario. I'm not certain you ever will completely, because there will be circumstances where individuals have come to work to do harm. We know that. I mean, there are national things. So maybe in some of those circumstances, you'll never avoid the independent investigation. But the problem with independent investigation was I went to East Kent for, I'm talking quite freely here, for 6 months, and was still there 3.5 years later. Because that was the time it took. Not quite that long, but you know, the last year was helping to support the implementation of reading the signals. But you know, 2.5 years to get answers from families, that's a long time.
No, thank you, Fiona, for your candour. John, anything to come back on that?
No, I suppose I'm frustrated as an independent observer of review process and CQC involvement and this kind of stuff, you know, and we can rename things, we can retitle them, but ultimately I think we have the data if we're prepared to look at it objectively and positively and honestly. And what we really require is that data to be used as the catalyst for continuous improvement across all providers. I understand why reviews are necessary, because people who've been harmed, particularly families and so on, want answers to what has taken place. But one would hope that by now we realise that relying on inspection and review is not the way by which we generate improvement and so on. We're just waiting for the next one to occur, I think. Despite the best efforts and of everybody concerned, but you know, it's the data that I think we've got to just use more intelligently and more honestly, and be able to acknowledge if we're struggling, because the data demonstrates that, and then we seek help, rather than what reviews tend to do is just frighten the heavens out of everybody involved, because all of a sudden a great unit of people descend upon you and start digging around. You know, that's difficult for people, I think. That's just my views anyway.
So your frustration with recurrent reviews, and really 2015 Morecambe Bay, and we go back to 2007, is shared by all of us who are very much embedded in maternity systems. And I can see Tony is itching to express probably his frustration with it as well, and we will come to it, which is why I've got Fiona giving us the overview and then Tony talking about some good stuff really that is happening, but also how the system failures have informed us. A couple of general points really, John. Reviews, independent reviews, are a privilege of being in the United Kingdom. I think they do not occur, they certainly don't occur with any regularity across the globe. But the sadness around that is that, and when I say we, and I'm saying this as an observation from lots of reviews, including those about the police, social services, etc., we seem not to be able to learn as a system, which is why I think sessions like this are really key, you know, and the data is so important. I did put in here, Fiona, that the data-driven approach is so critical, and yet we have so little of it in our undergraduate and postgraduate training as clinicians, whatever your profession. And really, I think it should be a non-negotiable bit now, as quality improvement should be as well. Can I open it up to any other specific questions for Fiona? So I might just come in with one, Fiona. I wonder if you would just explain, because not everyone who's here will understand the difference between assurance and reassurance. And I wonder if you could just clarify that for us, because that again is a really important piece in this systems thinking.
Okay, maybe I'll try and do it as an example.
Perfect.
So one of the index case that triggered off the East Kent was the death of baby Harry, and there was a coroner's inquest, and one of the key issues at the coroner's inquest was the locum involved sufficiently trained? And so a key action plan for the trust was to ensure that locums were sufficiently trained. And how do you ensure that they're in the right environment and the right place? There was a view that had been sorted. So the obstetricians said, well, we do X or Y, and it's all fine, don't worry about it. So that for me is reassurance, not assurance. So what we then do, and it is time consuming, but you need to satisfy yourself. So we took we used the internal auditors and we asked them to review the appointments of a number of locum posts, not just in maternity, across the trust, and to ensure that there were checklists in place, that each of the staff had been interviewed appropriately, that the evidence that they'd given about their skills and training was available. And that was put in a spreadsheet along with other evidence that was collected to say we have actually done this. And as far as possible, because we've done it in this systematic way, we're reasonably confident that the locums we've got in place at any point in time can work within the environment they're in. Now, that's not to say nothing will go wrong, because I'm afraid things do go wrong, but there was some basic systems put in place that didn't exist. But then we did an external audit about that. And there were a number of examples of things we did, but I pick on that one because it's quite simple.
No, thank you. That's really clear. So the difference between being reassured is very different to the assurance that you need. And I think it's critical, John, your question about why do we not look at the data? So at board level, where the accountability sits with the execs, again, the information that you are given is so important. And if you are, as you said, Fiona, overwhelmed with 40 pages at a board meeting, and that is but one bit of your organisation, the complexity of the data, the way you're trying to separate the noise from what's actually important is critical. And I just wanted to, Fiona, ask you another question just around. With East Kent, you very nicely said this wasn't just about maternity. There were processes across the organisation around risk assessment governance that weren't working, and it is those improvements across the whole organisation. Could you just give your reflections on how frequently you think that happens, or if we are still, to some extent, siloing maternity services because it's under scrutiny, because it's a little bit complicated, because it works in a slightly different way?
It's a very good question. I probably need the permission of the chief exec to talk about the detail around that. But actually, I could probably talk about a different trust, because wasn't it St George's where the CQC came in and said incidents were downgraded, which meant that you didn't have to do duty of candour. I think it was St George's. So I think there's some evidence in some of the CQC reports about how staff are not always as good at identifying the level of an incident, and therefore, if it's not sufficiently graded, then the danger is you don't launch into, or not launch, but you don't follow duty of candour, and therefore you don't involve families in the process. And I don't think, from what I know from reading CQC reports, it's not something that's abnormal to East Kent. It's something that happens up and down the country. And I mean, I'm a little bit out of date, and I have to be honest about that. But I mean, that there is a new reporting system, isn't there, for incidents? It's not something I've been hands-on because and I'll admit that. But one would have to hope that that system starts to address some of those issues, really. Does that answer your question?
Yes, thank you. So the new system, for those of you who aren't aware, is PSERF. So it's a framework. There are differences between how we report serious incidents, but one of the things that is of concern, certainly within maternity, and again, Tony may touch on this in his talk, is the categorization of incidents. So good units will tend to categorize them correctly. Units that are struggling may not. And I think, Fiona, you made that very important point about risk and governance, and ensuring that as many as possible clinicians are involved with that is absolutely key. But that certainly it isn't the case in all organisations uniformly. But then we come back to the issue of time, resource allocations. Fiona.
And I think it's a whole debate, isn't it, about where do the government staff sit? Do they sit within the individual care groups, or is there a central area? And I think probably, based on my experience in a number of trusts, not just in maternity, it needs to be a mix and match. But you don't want to have them in the care group at the expense of not having a corporate function with the right skill mix. And I think that is key for me about how it's a question all organisations should ask themselves. Are we devolving this into the care groups? If we are, we're going to have a central area with a proper correct skill mix that can have oversight of that to support it. And for me, that's been a tension in a number of trusts that I've worked in about getting that right.
Thank you.
Daghni, forgive me, I've just got an eye on the time. And
sure, we'll move on to Tony. So Tony, could I introduce Tony Kelly to those of you who don't know him? Tony is the National Specialty Advisor for the Maternity and Neonatal Programme. He's got a long-standing interest, experience in improvement at various levels of the system, including the new Muse score and the National Culture and Leadership Programme. So without any further delay, Tony, I'm going to hand over to you.
So I was trying to get myself off mute. Right. Can you see my slides?
We can. Tony, would you mind putting it onto slideshow?
I'm just doing that. It's just taking a while to catch up, Daghni. So there we go. How's that? Are we all good?
Perfect.
Perfect. Okay. So, and how long? What time's the session due to finish, Daghni? Just so I know, I might.
Do you know you're a mind reader? I was just we have it down till 2:30, so we have another 45 minutes or so.
Okay. Well, I'll trip through this in 20-25 minutes. So I think I'm going to take us in a slightly different direction now. In some ways, and thinking around how we manage deterioration, and I think broadly, although I'm going to use the way that we manage or detect and manage the deterioration in the pregnant mother, right? You can use, well, I hope you can use some of the thoughts and approaches I'm going to talk about here for applying to other areas, which is the purpose of, really trying to think about things more generically. Starting with a bit of a spoiler alert, I don't confess to have all the answers to this. I think I understand some of the issues, and certainly some that transfer across between both health settings and across care settings. I've certainly worked in organisations where some of the improvement work we've tried to do has gone across all of those care settings and within systems. I think we've been working in this area around maternal deterioration in a sort of consolidated way for the last 2 to 3 years, and we're testing some real life solutions around this. But I think the other thing to say is this is really hard. Actually learning is very difficult. And actually what we tend to be very good at, as was brought, sort of came through in many ways in that short sort of session we just had after Fiona's very comprehensive discussion, is we're quite good at pointing out what bad looks like, but actually the difficulty comes from trying to make the changes and learn. And so what I'm going to try and do here is potentially provide you a little bit of guidance around some of the approaches that we've used, some of the things to consider, and maybe some of the things to avoid. You will notice there won't be a lot of words on these slides. I'm not a great lover of you having to sit there and look at words, so this is all going to be fairly visual. So if that does mess with your brain and you don't like listening to my voice, I'm afraid you're in the wrong place. Firstly, what do we need by deterioration, I suppose? I mean, as I said, I'm going to talk about the pregnant woman within a hospital system, but we could apply this to any aspect of any patient care or a process within a hospital that might not be working in the way that we want it to. And we know that deterioration in perinatal services is a big problem. Fiona highlighted how it came out as an issue both in the identification and the response to escalation of care has come out in a number of the independent inquiries. It also comes through very strongly in reports into like Embrace, which looks at both perinatal deaths and maternal deaths. So we know that this is a perennial problem that's been going on for a number of years. And it's not just about the failure to identify, it's often failures to manage and escalate the risk effectively. And we're particularly challenged with pregnant women compared to some other clinical groups in hospitals in the fact that some of our most at-risk women are being cared for outside of their usual care settings. So we have to be mindful of the fact that some of the changes in physiology that we will see within pregnancy will be things that people looking after these women in medical wards, in accident and emergency departments and intensive care units may not be as familiar with. And so that presents another set of problems in relation to that sort of familiarity of what we're doing all the time. So let's try and get into this a little bit more. So I use this picture quite a lot as a way of starting a conversation about, are we certain that we know which problem we are trying to solve? Because a lot of the time, particularly in clinical perspectives, we tend to approach things very much from a solution focus rather than a question focus. And doctors are particularly guilty of this because I think we see problems as things that we need to be quick and active to solve rather than exploring the question. And often, sadly, I think we often look for easy solutions rather than the right solutions. And I'm sure this is irony of this sticker is not lost on you. I saw one of these yesterday when I was driving back again in the public toilet on in a service station on the motorway, and I just find it odd in so many ways that we don't think about, we're sort of highlighting a risk here rather than actually adjusting it by making sure that the water itself isn't going to cause harm. So, looking at trying to solve an easy problem rather than actually getting to the root of the problem is something that we're often not very good at. Now, we understand from a lot of work that's been done nationally that we need to be better at identifying deterioration. We need to be better at identifying not just deterioration of the pregnant mother, but also of the newborn child. And the ABC tool is an acronym for Avoiding Brain Injury in Childhood tool, which is an intrapartum fetal monitoring tool that's just in the final stages of development. So identification effective deterioration is really, really important. And we know we need to do that. But one of the dangers, I think, early on, apart from just making sure that we know we've got the right question to answer, is narrowing our focus just to one part of what is a much wider care pathway. And I think Fiona, again, very helpfully highlighted the way that we need to be thinking about pathways of care. And this is the pathway of care that may run across different parts of the hospital, but equally some of our care pathways need to run across systems. And we need to be thinking about all elements of this, and certainly within the deterioration space, although identification is an absolute central plank of effective management of deterioration of the pregnant mother, most of our problems come because we either don't plan and prepare well, but equally that once we've identified the risks and the issues that are afoot, we actually struggle to escalate and get the correct responses to them. So we need to think that we're looking at this as a pathway and not just as a singular tool that's actually going to solve everything. Now, one of the other mainstays of deterioration is we need this information in a timely way. And I think it's really important, and certainly, but Daghni and I have got, acute experience of needing to manage this sometimes in a very time acute way when we're looking after pregnant women who deteriorate. And I'm going to, excuse me while I baffle you with a little bit of science here, but if we were to look at on this graph on this slide with the idea of wellness on the y-axis and time on the x-axis, I was pleased that Fiona likes the idea of time series chart, so this is perfectly timely. We've got a green line which is showing our well woman, and then a red line which is showing a woman who's not so well, really, and the gap between the two is really our episodes of deterioration. And what we're trying to do is to bring that woman, wherever that sort of sense of deterioration is, back up to that well line. And the problem that we often have is we need to understand, how do we do that? Now, the simple way is that we think about physiology. So what we're going to do is we're going to be able to identify a change between what we would expect this woman to appear like when she's, all of the physiological parameters that she has are normal versus when they're not normal. So hopefully, if we've got a tool that's asking those questions, we should be able to actually work out whether this woman is unwell. But one of the immediate problems that we found when we started to dig into this, and this is a pictorial that's taken from one of the sort of the central papers that we've used to build the new national tool on, is there's a huge variation, not only in what is recorded in tools that are currently out there, but how people would differentiate between normal and abnormal. So the white areas being normal, the yellow and red, and in some cases orange being, ranges of abnormality. And as you'll see, there's a variation in, the sort of the areas that are represented by the different colors across all of these tools. And this was only really a sample of the ones that were available. And one of the interesting things is that most of this is built around the idea of consensus. It's not based on data. And actually, a lot of the cutoffs that we use were not built around changes from normal to abnormal, but often around the idea of when treatment would be implemented. So again, one of the other problems that we fall into is there's this huge variation in the way that we do things, and actually getting a much more considered and effective and evidence-based approach will allow us to do this much more consistently and also reliably. So one of the things we did in the national process is that we dropped down into using population-based data. We've simplified the way we approach things, so you've only got 2 degrees of abnormality. And this was then built and modeled using some centile modeling. And basically, to get to score 2, say, for respirations at over 25, you would be, your respiration rate would be higher than 99% of the population. So we can adjust that based on the fact that we know that the physiology tells us what's wrong. So that's something that actually allows you to have a much more robust process in when you're trying to understand what's going wrong. So basically, that would mean that abnormal physiology equals a need to escalate. So technically, you would think that that would be job done. But sadly, there's often more complexity in the system. So somebody might, in the one tool, might want to add in something like X being a reduced urine output, or they might want to add in vaginal bleeding, or they may wish to add in the fact that there was a concern by one of the clinicians, or there was a change in the pain score, or I don't even know what that equation is. I found it on the internet this morning. But basically, you then end up using a vastly complex system to try and understand when you need to escalate. And then what you end up with is this over-engineering of systems to try and actually help you understand when deterioration is afoot. And the reason NASA is there is one of the more famous over-engineering of solution problems was when the space program started, and NASA spent a good deal of money in quite a long period of time developing a pen that would write in a zero gravity space, whereas the Russians looked at it as, we need to be able to write something in space, so let's use a pencil. And I think one of the things about simplicity is you need to be thinking about the way in which you approach some of these problems so that we end up with the right solution, but actually the most straightforward solution rather than something that becomes overly engineered. So going back to our tool, what we've done is we've used physiology for the scoring, because that allows us to get an objective evidence of whether there is a change from what would be normal. But adding on to that, some of these, what they're called additional concerns. So they allow us to think about other elements of her care that may be happening, other concerns that we may have, and using those, you either augment or even independently of normal physiology, ask for escalation and a response to occur. So you're simplifying, but also ensuring that you're using the right approaches when you're trying to manage something as complex as deterioration. So be clear on the question you're trying to address, be clear on the role of the intervention that you're trying to do, and above all else, keep things simple so that you can actually understand whether you're making a change. But just drawing you back a little bit, thinking about the word early, which is particularly pertinent. We go back to our highly scientific graph. When is early enough? Because a lot of the time, if we're using interventions, we want to intervene as early as possible, because then the amount of intervention we have to do to recover that woman back to what would be normal physiology will be less. The further to the right you go, looking at this graph, the more intervention you're going to require. But you also have to be mindful when you're coming up with solutions like this about sensitivity of the tool versus the specificity of the process. So actually, are you over intervening, or are you intervening too late? So are you missing cases, or are you creating extra burden within systems? And so it's that balance that can often be very difficult. And really is trying to think also about the degree of intervention that you're needing. And this applies to all systems. So depending on how far out of line any system may go will dictate as to how much input you need, but also the amount of recovery interventions that you require to rescue it from where it may end up being. So I suppose what I'm trying to do is lead you towards where we've sort of got to. But there's one other thing I suppose I'm also very mindful of. A lot of places are very bad at asking others or looking for solutions from elsewhere. So you end up with this sort of blank page thinking. So everyone sits down and tries to reinvent the wheel. But equally, there is a really inherent danger with dragging and dropping something from elsewhere, because just dropping solutions in that have functioned elsewhere doesn't necessarily mean they're going to function in your own environment, because context is incredibly important as to why these interventions either do or don't work. So again, there is need to be quite a balance between the way that we operate in this space. But there's no doubt that having an effective national tool, as we're finding now, is very helpful. But a lot of that is around trying to create trust in the system. If you look at some of the psychology data around this, there tends to be opposition from things that are forced on people from the outside, but equally the speed with which people can develop something internally, particularly when you've got rare outcomes that we're talking about here, can be painfully slow. So we have to build trust as to why people would see an advantage with going with a national tool in that way. And equally, it's trying to understand where some of the opposition to this will come. Now, I tend to be by nature, I'm relatively on the far left of the innovation curve. So I'm a very early adopter of new innovations. But every now and then I find myself in the laggard space on the right. And I think it's very important that we're self-reflective sometimes to work out whether or not we're hindering a process or whether we're promoting it. But equally, are we making ourselves accountable to the organisation to be part of the solution rather than part of the problem? And I think when we're trying to manage things such as deterioration, be it of the pregnant mother or system failures, these two become really, really important. So I think points trying to make here is that getting upstream of the problem is really important. So rather than waiting for things to deteriorate so far that we've got a huge exercise and recovery is not helpful, we can do this much better, quicker by collaborating with others, but we need to be very careful that we're not dragging and dropping. And I'll talk a little bit more around the issues where culture plays out in a second. And then we need to be thinking about reliability and consistency in the way that we're doing things, because this is the bedrock of improvement. If you're not getting that reliability into your systems, it's going to be very difficult for you to actually recognize whether you've made any improvements. Now, something that we touched upon already was talking about inquiries and talking about failures. And I think one of the difficulties that we have at the moment is we do spend a lot of time focused on where things have gone badly, and we don't actually spend enough time focusing on where things have gone well. Now, that has 2 or 3 advantages. One, is very good for staff because we're focusing on areas through an appreciative inquiry sort of mentality where things have gone well and we can learn from those successes, and it helps build more robust systems. But it's really difficult to do. It actually requires a slightly different approach, and I think overall we need a balance between the two. But we're certainly using this approach much more in some of the wider work we're doing, particularly when we start digging into the culture space, because I think culture, as we've seen, is a perennial problem that runs across what we're doing. Equally, it's the one thing that tends to undermine some of the system changes that we want to make, and it sits at the heart of every system failure. But it's really difficult. But actually, if you approach culture from the point of view of this is what good looks like, rather than this is what bad looks like, actually we're finding through the work we're doing, and to reassure Fiona, there is a whole culture and leadership programme running across perinatal services now. It's using this appreciative inquiry approach to try and build and help people move towards what good looks like. And I think this is really important, particularly when we start digging into things like deterioration. And I'll quickly just take you through a couple of slides that sort of illustrate this. So we think about a cup of tea as an analogy about something that can be thought about. I'm sure you've all gone through this process of what you need to make a cup of tea, so you've probably process mapped it. But have you thought about the competencies that you need to make it, some of the materials you need to make it, but also some of the meanings that there are behind making a cup of tea? And equally, some of the values that you enact by making a cup of tea for somebody else. So if I was to make Daghni a cup of tea, actually, there's an inclusivity about that. There's a friendship element. There's some degree of caring. It extends beyond just the physical act of putting hot water on a tea bag. And the reason we've thought about this, and we've developed this with an academic partner when we've unpicked some of the interventions that we use, is if you take yourself into a situation where you need to escalate some concerns that you may have about somebody, there are a number of barriers that might be to why that might not go well. You know, particularly it might be that I'm at the other end of the phone and I turn into a bit of a monster at about 3 a.m. So you need to start thinking about the way in which we communicate. You can use technical interventions. This is a fantastic intervention developed by the RCOG and RCM called Teach or Treat. But what you sometimes need to do is to think not just about dragging and dropping this intervention, but thinking about the relational aspects of how you make that work. So within a culture space, how are we going to ensure, and Teach or Treat's quite clever because it stops this sort of adult-child communication and escalation process, and it's about peer-to-peer. And if you're sort of trying to understand what the person is concerned about, and if there is no concern, you're providing some education to understand why we don't need to do anything at that point. So there's a dual responsibility in the conversation. So it's going to require civility. It's going to require openness, listening to the way people are working. It's equally going to need a requirement of competency of understanding how to actively listen. So all of these things we need to think about when we're putting in place technical interventions. It's really important that we understand the values of culture that sit below them. And we can also use these spaces as a way of starting to learn how to, focus on the culture within our own teams, which then allows these interventions to embed further. And so you get into this beautifully cyclical interaction between clinical interventions and cultural interventions that work almost in synergy with each other. And it's one of the reasons why I think often these system failures that we see, when we try and fix them by putting in what may seem like relatively straightforward forward clinical interventions that might be relatively transactional or interactional, we forget to think about how culture influences the way that those will land. So a couple of points just before I finish. One is around measurement. So I think it's really important when we do things like this with any change, and this goes back to Fiona's point about data, we don't just celebrate activity. So we don't just implement something and that's the goal. What we should be thinking about doing is, what are we going back to the original question? What were we trying to achieve here? So what was it that this tool or this process is trying to do? And how will we know that a change is an improvement? And that can be quantitatively, it can be qualitatively, but it can always be measured in some sense. And I think having some sense of measurement, be it for the intervention or for the whole pathway, I think is really important. It's actually proving quite difficult in maternal deterioration because we don't have easy sets of metrics to fall back on. And it's one of the problems, as Daghni highlighted, we've got the Reading the Signals group running at the moment, and trying to understand in an effective way how we can look at the impact that maternal deterioration has on something like mortality is really difficult, because these events happen rarely, and how can we get early signalling? And I think some of the areas of caution that we need to be really mindful of at the moment is we can have some of the best systems in the world. And I think it's unfortunate that people living in this country don't really understand how safe having a baby is, because it is remarkably safe. But unfortunately, we are seeing it, and increasingly, that we are failing some groups of women, pregnant women in this country. And I think these data that come from the last Embrace report, the fact that we still have, as a black woman, you being 4 times more likely to die when pregnant compared to a white woman, is stark and startling. And I think some of the processes that we're putting in place, we need to understand how we can address these inequalities and inequities in the way that we deliver that care. And certainly within the current maternity and neonatal programme, we're trying to build some of those in to understand how we can do it better. And some of the evaluations that we will do will also look at that. And again, we've got similar problems mirrored when we look at deprivation. And I think we need to be very careful that we don't sidestep this when we're actually trying to put good processes in place. And for me, a system is still failing, even if we find that there is a disproportionate outcome for certain groups that we're looking after. And I think we need to be very careful about that. And that's really why I think the power of something like an approach of proportionate universalism is so important, because we can start thinking about how we can best invest our money. I think we also need to be mindful of context. And I think this came up earlier in the way that we're looking at this. The system is running really hot at the moment. I mean, we have a lot of very tired, exhausted, and somewhat upset staff. You've got a lot of senior management who are running under high pressure and balancing various sort of often competing priorities, and we're time and resource poor. So trying to make some of these changes in light of all of that is very difficult. But we do need to be trying to find a way to do that. And equally, trying to make changes in a system where there is very little wish to make improvement is also very difficult as well. So finding the right time to do change is something else we need to be very opportunistic in the way that we do it, and we need to be mindful of how much we're asking the system to do. And certainly within NHS England, we are part of that problem, because we're often asking the system to do too many things at once. But I think we also have a very exciting opportunity on the horizon. And I think as we move into a much more digitally mature space, and this is something that is a struggle at the moment in the way that we're trying to do it, but we have the opportunity whereby digital systems will support our clinical decision making much more. And so pulling some of the human error out of there and actually providing people with guidance about how they respond in real time, let alone the idea that we can build AI and some larger data set analysis into the way that we move forward, so we understand where system failures are starting, I think is going to be really, really exciting. So I think I've talked about most of that. Martha's came up earlier, and I don't think I can go talk about deterioration without talking about this, because I think it, what Merritt Mills wrote about the death of her daughter, I think left most people feeling absolutely harrowed And I was furious. And I think Anne Batchelor's comment on Twitter about this whole idea about ego, I thought was really interesting. When you go back to what we're talking about here, which is deterioration, system failure, and the fact that ego is still getting in the way in, 2024, I think is frankly terrifying. So the fact that we have something coming in on the back of this, which should allow a little bit more external support, I think is important. But again, how will that land, and how will we manage that? How will people be open to the challenge? Will reflect on the cultures in which we work in. And my final point, which I think again hopefully loops back to where we started with what Fiona was saying, is it's interesting. This is taken from an organisation with a memory, which for those of you who hopefully will be old enough to remember it, this will be 25 years old next year. And this still rings true today as it did when it was first published. And I went back and reread the foreword from Alan Milburn and from Liam Donaldson yesterday. And I think so much of this is about moving into a space around learning and not just, looking at where we're failing, looking at being much more open around errors and collaborating about where we can learn from each other. And it's just this system-wide approach, and actually, as Fiona said beautifully earlier, it's the systems that let our patients down, not individuals. So systems thinking and understanding how that they can be better structured and delivered, I think is going to be really critical. And I just think it would be interesting if we reflect on this next year as to whether we feel we've actually moved forward at all from when it was first published. Anyway, thank you very much, and happy to take any questions.
Thank you so much, Tony. I wish you did make me more cups of tea, because it's always enlightening to listen to you. John has a question. John, can I get you to ask your question?
Yeah, sure. I was really interested, Tony, in when you were talking about the use of technology and tools and so on. And I've always thought that it was the case that you always get the early adopters, the enthusiasts, the people who have used a particular tool and they're confident and competent and optimistic with it. And then you get another cohort that remain to be convinced, and you get another cohort that just rejected, and clinically that creates an inconsistency then that is potentially tragic. And I just wonder whether you could comment on how do you promote to all clinicians within a particular discipline that a particular new tool that's been analysed and verified and tested by NHSE and various groups and so on has to be adopted and used positively. It strikes me as an important thing and a difficult one as well.
Yeah, I mean, I think it's a central issue that we have, and it can be potentially tricky, but because in many ways we don't have the opportunity to enforce this. There is such a weak evidence base in this area that even News 2, when it was first published, the validation of the tool has happened after it went into clinical practice. So, the validation and evaluation of this tool and process and pathway will be 3-4 years hence. So we can't kite mark it, we can't enforce it. But in many ways, we've taken that as an opportunity. So what we've tended to do is to go to people and say, look, what we've done is we've looked at where the potential vulnerabilities in what we're doing at the moment are and trying to minimize those. So we've got an effective system that's trying to get upstream of the problem. We've got an effective system that's based on population data. It has a degree of validity. We've done some modeling to show how this performs against other parts of what we're doing. We're wrapping a bigger piece of work around it, so we're not saying this is a tool that's going to fix everything. But most of the time, and we've curated this process so far, so we've got 16 organizations gone live with the tool so far, and the digital specifications will be ready by the beginning of the summer, and so we can then start going to a much larger sort of national implementation process. But we're learning as we go as to what the issues are, and then we're reflecting that learning back. So we're not just putting it out there and saying you must do this. We're trying to make it very personal, because I think a lot of the time large scale change, particularly when it's enforced, can feel very impersonal. And once you do that, I think you create isolation, you create pushback, etc. And so I've tended to be inquiring as to why people think what they're doing might be better, because genuinely, if it is, great, we'd like to know about it. And we've spent certainly the last couple of years exploring some of those issues with people. And so far, I mean, there's a couple of exceptions, but so far, everyone else has really come to the idea, well, actually, great. If you think that that might work, then, we're going to give it a go, and then we'll keep you informed as to how we progress. And, we've just been very transparent about it, John. And I think the danger sometimes is that we come across as being too certain of a solution when actually it's untested.
It's a really refreshing mindset to hear. I like the sound of that, and I think Daghni's added in agency and advocacy, as twin supporters of that. But I'm very encouraged by that. Thank you.
Thank you.
Thank you. So I'm open any panel questions really for either Fiona or Tony. And there are a few bits that I've just been adding to the chat. So if anyone has any questions, could you please just pop your hand up or unmute and shout out. And if you do, please, could you just introduce yourself so the speakers have an idea of who it is. I am going to ask both of you a question based on what you talked about, Tony, in terms of over intervention and under intervention. So we move away from a clinical situation into systems. And I like to think about things as systems, and I think most of the time things can be connected. That balance between over intervention and under intervention of various parts of the system, with the obvious bits of the system that are struggling. So in this case, we might have East Kent, who are now in the sustainability phase, but were on an improvement phase, and how the system around them either over or under intervenes. And I want to know what both your perspectives are from that. Fiona, do you want to go first?
Yeah, I mean, I think it depends what you mean by intervene. Because I think, intervene is often about asking questions or, kind of saying that's not good enough, rather than supporting the journey of improvement. And for me, that is kind of the key issue, really, because there is no doubt, and I've always worked in challenged organisations, I have a history of that people are looking over your shoulder all the time, and you spend more time answering their questions than actually getting on with the improvement work. So I'm really keen on intervention being supportive and doing and hands-on, as opposed to, well, what went wrong, and here, can I have another report about it? I don't know if that answered your question, but for me, yeah, that it's really quite key. And I think I've watched it a number of times where people are trying very hard to implement their improvement, but spend more time answering what went wrong or what they're doing than actually doing the doing.
Yeah, no, thank you. That's helpful. And just before I come to you, Tony, you probably are going to allude to something in this. I think there is a leadership task at every level as you go up and or down to lessen the grip. The more troubled an organisation is or a system is, to allow them to get on with the doing. And I think that the burden of reassurance keeps coming and coming, and that's something that we've been really mindful of across the regional teams and the national teams. Tony.
I think this is particularly difficult, and I think is going to become more pertinent in the next sort of 12 to 24 months, because as you know, Daghni, a lot of the assurance function that was sitting very much centrally within NHS England has now been devolved down to both the LMNSs and, or more, the integrated care boards. And I think those system leaders are, and those systems are at very different stages of maturity across the country. And the way that they work with their organizations, therefore, is very variable. And so I think part of the way in which an LMNS or an ICB will respond and work with a particularly challenged trust is very dependent on the maturity of both of those organizations and the way that they interact. And I think in an ideal world, the assurance sort of process should be less of the conversation, and it's more around the critical friend. It's more around, okay, I appreciate this is the issue, but what have you learned and how are you moving that forward, rather than it always being around, well, these numbers would suggest you have a problem. And I think at the moment the difficulty is that the ICBs and the LMNSs don't know how they can flex in that space, which is, I think, is going to come down to the organizations. Equally, their frustration is the open organizations who understand what their problems are, their culture is very good, they're very happy to chat and they want to permanently improve. The organizations that are really in trouble don't know they're in trouble. You know, Bill would say openly, why we need some of the reading the signals work is these organizations weren't aware they're about to career off a cliff. So, you know, you do need a balance between the two. But I think once you have some sense of a problem being understood, then I think rather than it being, as Fiona's saying, it's all around, you know, tell me what's going wrong. It's about building a sense of, well, let's help you understand where the issues are and how you can start to rebuild. And certainly when you speak to colleagues in East Kent, and I've got some colleagues, friends at SAF, the morale in these organisations just falls apart so quickly. And therefore you hemorrhage staff as well, and then it becomes increasingly difficult. So I think it's really hard. But I do think we need to get a balance between the kind of questions we're asking and maybe, yes, we need to focus on making sure some of the governance is correct, but I think we also need to be focusing on trying to ensure that we're building confidence back in the staff, creating positive cultures, creating agencies, supporting the leadership, you know, the things that will make sustainable change. And as we've seen, there's a number of organisations that have gone into the maternity safety support programme that have come out and then have come back in again because they've not been able to sustain those improvements for you know, a raft of reasons. So I think it's a complex issue, as you know full well. So
thank you, Tony. So to that, I was going to come to, given the fact that we're talking about systems and learning, and this concept, recently a couple of you have heard me talking about it, of systems emotional intelligence at every level, and that balancing of the criticism versus the support and the varying roles and the tension within that. And I know I have some colleagues from Southeast England region, and again, we were very mindful in that series of Ockenden visits to every single unit to ensure that we were also crediting and highlighting good work, because it's a really difficult ecosystem at the moment, I would say. Can I just check if there are any other questions? Because I'm just going to ask Tony and Fiona in a second to just give some. I wanted to know, what would you, if you had a magic wand, what would be your one thing that you would want done to improve system learning? So whilst and there's a question actually from Mo, so if you can sort of think about that in the background. And Mo's question is, what role do you see in maternity safety sustainability for the Maternity and Neonatal Voice Partnership Programme? So what role do you see in maternity safety sustainability for the MVP Partnership Programme? I don't know. I'm going to put you on the spot then, Tony. Would you like to give that a go?
I mean, I'm not sure so I suppose there is some synergy between the answer I would give to your question and the one that I would give to Mo's. But I think one of the things I would like to be able to do is to do quite a lot of decluttering. There was a fantastic article in BMJ Quality and Safety about 18 months ago now that was written by Charles Vincent, which was looking at some of the philosophy behind our data sets. So rather than thinking about looking at the same problem from a variety of different aspects, we actually think about how different measures or metrics complement each other, so that we thin out actually what we're looking at, and we can have a comprehensive 360-degree view of what an organization is doing. So let's not just worry about the safety, let's not just worry about the performance, but let's equally think about how we're addressing the experience of care that sits within that, both for the people who are accessing care, but also the sort of the safety climate of the staff that work within the organization. So if we could declutter that space and make it far more sensitive and specific, but really pare it down, because I think what we've done is we've layered and layered and layered. And I think that would allow us to be able to get a much more effective view of the system, but equally it's sort of being able to understand how the voice of the women and the families that we look after is much louder than it is at the moment. And that's not, because I think it has some degree of influence, but I think in the same way, if I go back to my early warning score thing, if you just look at the physiology, you'll get the right information. If you add loads of other bits into the score, you diminish the value of the physiology. So let's try and declutter the space and make the right information come forward, but make sure that we're looking at the right things.
Thank you very much. So that's a really important role, Mo, for the Maternity Neonatal Voice Partnership Programme. And I just, as you're both thinking of your magic wand thing, decisions really, whether we're making them within the teams, individually with our patients, or at system level, generally are dependent on the information you have. We've spent a lot of time talking about data and your synthesis of that information, and then judgment, which comes into it. And I think within that, we've got to be absolutely certain about our own biases and our own discrimination. And then that thing called experience, doesn't it? The intuition. And a lot of obstetricians and midwives will say, well, I can literally feel it in my waters. I know she's going to run into problems, or I think, and that being able to then synthesize all of that together requires that headspace, that emotional intelligence, that ability to harness, I suppose, the experience, collective wisdom of the team is important. And within that, being able to appreciate the patient perspective each and every time we make decisions at every level, so important. We know it's the right thing to do, but the doing it is often not so easy. So thank you very, very much, Fiona and Tony. Now I feel a bit like this is Desert Island Discs, and you have your magic wand to take to your island to sort out systems learning. What would be your magic wand one thing?
Mine's very much about culture. So I think that I'm very struck by words of Michael West about the importance of compassion and how that leads to belonging, and actually recognizing that staff have lots of difficulties and families outside the NHS, and we can't solve it all. But I think it's about a style of leadership that's compassionate, and that is compassionate both to families and to staff. And for me, that's really important.
Fantastic. So the right culture, going back actually in origin to the 2015 West paper, I think it was staff engagement is an excellent barometer for the performance of an organisation in the whole. And Tony?
I would completely agree with that. I think it's, that, and I find that so encouraging to hear that from somebody who has had to operate in an environment where you've been looking after very hard-pressed organisations during a very difficult period of time when, you know, senior NHS leadership was very much around directive pace-setting styles. And, you know, the fact that that's central to the way that you would want to work, I think is, you know, very encouraging for certainly what Daghni and I are trying to embed in the way that we're moving leadership forward. So yeah, I would agree with that completely, because and the more, you know, there's so many case studies of when we focus on the well-being of our staff and the culture within our organizations, then the care that they deliver improves. So you know, if we can do that and find a way of making or being even able to create the spaces in which that happens. And I think the focus we've now got increasingly on learning systems, where, you know, this sits centrally to the way that that works. If we can start showing how that's going to function, then I think it will be easier for us to sort of get more support for it. The problem I think we still have is most people feel that the good continue to get better, and those poorer organisations get left further behind in some ways. So we're increasing that inequalities gap in some senses, but which is, you know, is really problematic. But no, I think that's a really lovely point.
Oh, what a nice way to end that on that circular thing, back to the magic wand. So from me, thank you both for taking time out, for allowing it to be recorded, and for your insights and reflections to be shared. That there's something, isn't there, about radical candor of our systems, that level of openness, honesty and frankness, so that we can move forward, but at pace. So my thanks to both of you. And John, I'm going to come back to you to close the session.
Thank you, Daghni. I just echo your thanks to Fiona and Tony. I feel actually quite uplifted. I feel quite positive about what I've heard. I mean, half of me was expecting quite an intense session about review and inspection and so on, and you've both been rather the antithesis of that, and I find that, yeah, very refreshing and uplifting and reassuring, actually, that you know, we've got good people in senior roles and so on who are looking at it through this sort of fresh lens. So yeah, thank you for that. Really appreciate your insights and your enthusiasm for the topic as well. Daghni, as well, if I may, thank you to you for teeing all of this up. This fits so beautifully with a lot of the new work that the Institute is going to be promoting on QI in particular, and system leadership in the second half of this year, that we're beginning to draw together quite a lot of resources in that regard at present. And then we'll be looking at a short course masterclass for our members on that topic. If I may as well, I think Mo was asking about the paper from Professor West. You might also, Mo, there's a fantastic book by Michael on compassionate leadership, written in collaboration with Welsh partners, Health Education Improvement Wales. It's a really good read, available from all good bookshops, Amazon, usual places, etc. And if you want to come along and have a look at compassionate leadership on one of the Institute's forthcoming Power Hour events, when we'll go through some of that stuff, then you would be very welcome. But for today, can I just thank everybody for attending, small but perfectly formed, and looking forward to the next event when we look at another GSTT Showcase session. Who knows what it may be on, but you can be sure it'll be another blockbuster. Thanks very much, everybody. Enjoy your weekend. Dodge the storm, hunker down, but, you know, above all, peace and good health to all of you. Thank you. Bye-bye.